by دكتورة سارة وحيد طنطاوي, lecture of radio diagnosis in Shams University.
Thank you so much for the kind invitation and kind welcome. I would like to first thank my colleague Samah Khalil for helping me in preparing the material of the lecture and for allowing me to present on his behalf. I'll be talking about guidelines and what should be reported in a case of cardiac MRI. Actually, my lecture will be somewhat overlapping with Dr. Dunya's lecture, so let's consider it as a form of quick revision and to stress on the main points of the report elements. First, to start off, what are the advantages of CMR? First, there's no radiation at all. Second, it has a relatively high spatial resolution, not the highest, but it's still high enough. 3, it's easily reproducible, so easy to use it in follow-ups. 4, you can easily determine both LV and RV morphology and function since you get cine images ECG gated. 5, you get to differentiate different kinds of cardiomyopathy like we saw. 6th, it has a very high capability of tissue characterization since we have a very high contrast resolution, so you can differentiate edema from iron, from fat, from fibrosis, and so forth. Quickly going through the main basic cardiac MRI technique. As we all know, our main enemy in cardiac MRI scan is that the heart is a motile structure. So in order to scan it properly, we need to have ECG gating, and this can be done prospectively or retrospectively. Actually, in MRI, mainly we rely on retrospective gating since we need to know or get information about the function of the heart, and in order to do that, we have to do a whole cardiac cycle examination. The second enemy in our scanning process is that the heart actually doesn't lie aligned with the axis of the body. It's rather oblique, in an oblique direction, and it has to be individualized actually in the MRI acquisition protocol in order to align our plane acquisition with the exact cardiac axis. And the planes we actually use are based on the HA recommendations. They are both longitudinally oriented along the longitudinal axis of the heart or a short axis oriented, so that's perpendicular on the LV axis. So what we do is we generally take scout imaging in the form of sagittal, coronal, transaxial sequences. So these are like basic fast spin echo sequences, or what we call SSFP, that's steady state free precession sequences. And then we use those for the accurate planning along the cardiac axis. First, we take black blood T1 weighted images. That's for the purpose of knowing the anatomy. And then we take what we call the cine images or white blood images. These are the most important sequences that we mainly rely on getting an idea about the whole function of the heart and about the volumetric data of the heart. And of course, we acquired those, as we mentioned earlier, along the longitudinal axis of the heart. So we get 4-chamber view, and then 2-chamber view, 3-chamber view along the LVOT. And we get short axis view, like we said, it's just perpendicular along the axis of the LV, and we get a whole stack of images. And we actually mainly rely on these images to detect regional wall motion abnormalities and to use those images in order to compute and quantify the exact cardiac function and volumes. Second, we take T2 fat sat images, what we call stare images. These are mainly for the purpose of edema detection. And then, most importantly, like Dr. Dunya just mentioned, the late gadolinium images, CMR has a superior role in being the only modality that actually can directly visualize the scar. No other modality can actually do that. And using the late gadolinium imaging pattern, you can actually differentiate whether this is an ischemic cardiomyopathy or non-ischemic cardiomyopathy. As we said, the ischemic cardiomyopathy, you get subendocardial or transmural enhancement in a territorial fashion, and the non-ischemic, you get mid-ventricular, subepicardial, or global subendocardial enhancement. So these are the different patterns that guide you whether you're in an ischemic pathology or you have other non-ischemic patterns. So again, this is a subendocardial enhancement that goes with ischemic cardiomyopathy. The DCM, as we are going to see later on, it gives you like mid-ventricular enhancement. Patchy enhancement goes with hypertrophic cardiomyopathy. Myocarditis gives subepicardial or mid-myocardial enhancement, or like here, a subepicardial as we mentioned. Amyloidosis goes with more global subendocardial enhancement. T1 mapping native and ECV values actually allows you, that's a relatively new technique, and that allows you to directly quantify the amount of fibrosis using T1 actual quantifiable values. And this is superior in detection of diffuse fibrosis on a microscopic level, even if it's not evident yet on the late gadolinium images. So running through the main indications again of the CMR, first you use CMR in ischemic heart diseases in order to detect ischemic and viable or non-viable myocardium. You use it in cardiomyopathy in order to differentiate different types and for risk stratification of the cases. And you can actually calculate the exact scar size using post-processing methods. You can use it in iron assessment in iron overload cases, like in cases of thalassemia. You can use it in inflammatory conditions, and that's actually booming nowadays since we have the COVID era. We use it in congenital heart diseases in order to detect hemodynamics and understand what's going on within the vasculature. So quickly running through the main points in each cardiomyopathy type. So ischemic heart diseases, we want to really know or answer a question that is whether you need to revascularize the vasculature and let the patient go through the revascularization technique, which are like cabbages or PCIs, or not. So that question is ideally answered by the late gadolinium images. If you hello, okay. So if you detect a scar that is less than 50% of the scar of the diameter of the myocardium, that's considered to be a viable myocardium based on many previous studies. So these are actually the patients that need to go and get revascularization techniques, because these are actually the patients who will benefit from such techniques. It has been proven that if you have a scar that is more than 50% or transmural scar, these patients will not benefit from such techniques. So it's really a cost-benefit issue or balance that you need to answer. You can actually do stress-induced images and inject a stress-inducing agent and detect actually ischemic myocardium that is not there yet, not forming a scar yet. So as you can see here on the left-handed image, there is a transmural perfusion defect in the LAD territory, and here there is a subendocardial perfusion defect in the RCA territory. So that's ischemic pattern of perfusion defects, and it's not forming a scar yet. You can also detect myocardial infarction complications like aneurysmal formations, like thrombi, which is detected as a hypointense intracardiac mass in all sequences, pericarditis accompanying the myocardial infarction, or even cases of myocardial rupture who are lucky enough to pass through it. In cases of myocarditis, you need to answer two questions: whether there is edema or late gadolinium enhancement, or scar formation, and these are again, like we mentioned before, easily answered by MRI by using either mapping techniques or just the stare images. or using the late gadolinium images and the T1 mapping techniques. So you need to have one of each of those findings, either the mapping or the native findings. Cardiac MRI has actually emerged as an alternative modality for diagnosing pulmonary embolism, especially in cases of pregnancy or in patients who you cannot use CT contrast. So you can just do regular SSFP ECG-gated sequences in order to detect pulmonary emboli. You can use it in cases of pericarditis, like we mentioned, so you have like intense pericardial enhancement, like in this case, and you get the septal motion bounce, like we showed earlier. So in different types of cardiomyopathy, the role of MRI is very high in cases of HCM. So you need to focus on determining the phenotype of the HOCM patients, whether it's septal, which is the most common morphology, whether it's apical, whether it's global, just symmetrical, concentric, or even mass-like, where you get to differentiate actual intracardiac masses from HOCM pattern. You need to answer the question of the function, whether the, usually in cases of HCM, you have supernormal function of the cardiac heart, but if you get lower values, that means that the heart is actually starting to get in the burnt out phase, where you get dilated LV and low ejection fraction of the LV. You need to answer the question of the LVOT obstruction, whether there is LVOT obstruction, and we actually use that or assess that visually or by the Q flow, as we mentioned earlier. It gives you the advantage of actual direct quantification of the peak velocity throughout this area, and you can indirectly even calculate the gradient along this plane. You need to answer if there is associated systolic anterior motion of the mitral valve, where you get systolic motion that actually adds to the LVOT obstruction at this region and leads to secondary mitral regurgitation. All of that will add to the value of the MRI in answering the risk stratification of the patient. So you answer the LV maximal wall thickness, you answer the LVOT obstruction and its grading, LV dilatation, decreased ejection fraction, fibrosis. And fibrosis actually, mapping helped a lot in quantifying the fibrosis, like we mentioned, because in many patients of HOCM, even though there is no scar formation, but you get global high values of the T1 native and ECV values. In cases of DCM, you need to focus on the delayed gadolinium enhancement pattern, because many cases of dilated LV, that actually can be secondary to ischemic pathology. So you need to differentiate whether there is an ischemic pattern of delayed gadolinium enhancement or the DCM primary pattern. As you see here, there is mid-ventricular fibrosis, which goes more with the primary dilated cardiomyopathy. And this is another case showing subepicardial enhancement as well. You need to answer the function question, and this is easily provided by the CINI images. In cases of ARVD, arrhythmogenic right ventricular dysplasia, you need to answer, actually MRI is very superior in diagnosing cases of ARVD, because they are relatively hard cases to diagnose. So you need to answer questions about whether there is regional RV wall motion abnormalities, plus if the RV is dilated enough or the ejection fraction of the RV has fallen to meet one of those criteria. So it's either reaching the major criteria or minor criteria, and based on that you can actually answer whether this case is an ARVD case or not. And in addition to that, you can actually say if it's biventricular or just the RV that is affected. As you can see here, the RV wall is showing dyskinesia and like aneurysmal dilatation of the RV wall. So that is actually one of the major criteria, like we mentioned earlier. In addition, using those CINI images, we quantify the exact RV volume and RV function. In cases of amyloidosis actually is one of the diseases that causes diastolic dysfunction and then systolic dysfunction. The amyloid material infiltrates the myocardium, the valves, the coronaries. It starts in an asymmetrical fashion and then extends symmetrically. And the role of MRI is actually to differentiate amyloidosis from other patterns of cardiomyopathy, so you get diffuse subendocardial enhancement, and the more extensive the fibrosis gets, you get difficult nulling of the myocardium during the acquisition of the exam, and this is kind of sensitive and specific. You get, if you're lucky enough, if there is an interatrial septal thickness of more than 6 millimeter, that's very specific in diagnosing of amyloidosis, and you can get other concomitant findings like pericardial effusion in that case. You get to answer the question whether there are like intracardiac thrombi, which are pretty common in those cases as well. We use the superior tool in amyloidosis, that is the mapping techniques. It gives exquisitely high values, higher than any kind of cardiomyopathy, so that's a very powerful tool to be used in cases of query amyloidosis. In congenital heart diseases, we have the superior advantage of quantifying what is called the QPQS, and this gives an indirect quantification about the intracardiac shunts or extracardiac shunts, and based on that, if the shunt is significant enough, the patient can go directly to surgery or cath repair of the shunt. It's beginning to be an emerging tool in post-operative assessment of tetralogy of Fallot patients, especially in adolescents. And it's becoming more or less routine test in order to detect post-operative complications. So we have direct assessment of the pulmonary regurgitation through the Q-flow images, and it allows you to exactly quantify the regurgitant fraction through the aortic, the pulmonary annulus. You can also detect the wall motion abnormalities of the RV, like akinetic or dyskinetic or aneurysmal wall segments that are actually can be the focus of starting to get arrhythmias and sudden cardiac death. And there is associated decompensated RV, so again, MRI easily allows you to quantify that. You can also easily detect whether there is residual stenosis with a subsequent RV hypertrophy or not. That's it. That's my end of the presentation.
Thank you, Dr. Sara Wahid, for this presentation. I know it is very difficult to make a review of all findings of cardiac MRI in 12 minutes. Thank you. ونكمل نساطع إن شاء الله في سماء الكاردياك إيمجينج.